Hello. Thank you. So Mike asked me to talk about this tonight, so I was kicking around what you'd want to know. So I'm going to give you a little bit of idea of what my objectives are and see if that sounds good to you, and we'll just roll with it. Feel free to ask questions as we go, and ask for more information or less. I just was trying to figure out what you might want to know, and I didn't know quite what the audience would be. So let me play with this a little bit. And you said just push it. Sorry, I got to.
Middle's laser pointer, the sides are the moving forward and backward.
Okay, there we go. So my objectives tonight, I thought, would be define what a heart scare might be, because it could be a lot of things. Briefly discuss some of the most common cardiac problems that occur. Briefly discuss typical interventions that might occur. And then discuss cardiac rehab and the benefits and obstacles, because basically most people that are going through a cardiac event are referred to cardiac rehab, and that's where we help them get their life back. So that's let's see. So what the heck is a heart scare, right? So a lot of times when people come to cardiac rehab, we talk about them having a heart event, and they always kind of laugh, well, why do you call it a heart event? Because there could be any number of diagnoses that actually bring them to see us in cardiac rehab or to cardiology. So a cardiac event is something that causes you to seek or need medical care. So it could be acute coronary syndrome, and I'll explain what these are, but it's just got a quick overview. Acute coronary syndrome, which is ACS, myocardial infarction, which is a heart attack, angina, which is chest pain, heart failure, which is a weakened heart that doesn't do as good a job, cardiomyopathy, which is an enlarged or weakened heart, broken heart syndrome, Takotsubo syndrome, which is kind of interesting, is a cardiomyopathy. It's actually transient. We'll talk about a little bit about that, but it actually can cause a heart attack. And it's usually caused by a sudden, huge stressful event, a loss of a loved one, and it causes this crazy hormone surge that actually can cause a heart attack. Valve disease, which we detect through heart murmurs, sudden cardiac death with resuscitation, and cardiac arrhythmias. So I'll explain a little bit more about these. So a heart attack, or myocardial infarction, is actually when you have blood flow that brings blood to the heart muscle itself, and that's through your coronary arteries. And when there's a blockage in that blood flow, if that blockage is complete, it loses oxygen as well. So I'll back up just a little bit. Every tissue, cell, and organ in our body needs oxygen to function, and the blood carries it there. So with a heart attack, when you have the blood supply is cut off, then the oxygen is cut off. And if that goes long enough, where that tissue is without that oxygen, the cell starts to die, and then we have death. And so then what happens is with the myocardium, which is the heart muscle, it leaks an enzyme into the blood from that damage. So when you come to the emergency room, we'll come in, and when they first come in, if you have chest pain, they're going to call it ACS. It's a kind of a catch-all phrase, something acute coronary syndrome. But what they're going to do is they're going to do a series of lab work, blood work, to see if you have that enzyme present. They'll also do EKGs and stuff. They use different criteria. So if they find that enzyme present, then they know, plus with some other criteria, then they know we have some injury here, and then they'll usually rush you to the cath lab. We'll talk about that. Angina usually has the classic signs of chest pain. It can be the pain down the arm, jaw pain. There's quite a few different symptoms that can be included under angina or a heart attack. But the enzymes aren't released. It's a reduction in blood flow, but it's often not a complete reduction, a complete cessation of blood flow. And so there's no cell death, and the enzymes aren't leaked in there. But it also is a precursor to having a heart attack, so we want to pay attention to that and follow through. Heart failure isn't necessarily the heart isn't necessarily failing, but it doesn't work as well. The muscle is weak, and it doesn't pump as well, so the cardiac output is reduced, and it doesn't do a very good job. And what happens is the blood starts to back up in the system, and it can back up into the lungs and the lower extremities, and have swelling or shortness of breath. Valve abnormalities. We have 4 valves in our heart. There's 4 chambers, and they're divided by 4 valves. And sometimes those valves become incompetent. They leak a little bit. They might get stiff, and we call that stenosis, where they get stiff and they don't close all the way. They might be leaky. We call that regurgitation, where blood flow goes backwards through the system. Or sometimes the valves have leaflets in them, and sometimes they prolapse and go backwards, and so the blood flows the wrong way. So with any of those issues, we stage valve disease in 4 stages. Stage 1 to 2, you can live forever and have no problem. But if it starts advancing to stage 3 or 4, we usually have to go in and either repair or replace. Cardiac arrhythmias and sudden death. So cardiac arrhythmia is abnormal rhythm of the heart. It could be a fast rate or a slow rate or an irregular rate or a cessation of the rate. So, that's what under cardiac arrhythmias. And then, as I mentioned, the cardiomyopathy, the Takotsubo syndrome, is usually have a sudden crisis in your life, and this surge of hormones that are released can actually cause a heart attack, can cause enlargement and a cardiomyopathy. It's often transient, and it often does go away in time. But we can take them to the cath lab. They clearly have had a heart attack, but their arteries are clean. There's no blockage in there. But it's this crazy surge of the hormones. So while the causes of these cardiac issues varies, it's either an electrical problem or a pump mechanical problem. So we call it electrical. We treat it by the electrician. That's an electrophysiologist, which is a cardiologist that specializes in the electrical part of the heart. As I mentioned, those electrical problems could be rhythm issues. So ventricular tachycardia, we call it VTach, or ventricular fibrillation, we call it VFib. So your heart has your 2 upper chambers called your atria and your 2 bottom chambers called your ventricles. And the bottom ventricles is what is called the ventricles, and when they go into the abnormal rhythm, it's often fatal, so we need to treat that quickly. The top part of the heart, the atria, can have tachycardia, which is a fast rate of the top part of the heart, or a fibrillation of the top part of the heart where it becomes irregular. And then bradycardia or heart blocks, I'm sorry, my throat's really dry, or the bradycardia are called heart blocks, where it's slow or there's a block where the electrical pathway going through the heart, there's interruptions, and they take different pathways. And then, of course, cardiac arrest, as I mentioned. And so these are, the specialist is the electrophysiologist, cardiologist that takes care of the electrical part of the heart. Then I like to say we have the mechanical, the pump part, and we send those to the plumber. So that's going to be your your interventional cardiologist, who might take you to the cath lab and work with you, or your cardiothoracic surgeon who will help with you. And those kind of problems are your blocked coronary arteries, like I mentioned, with angina and a heart attack. The problems with the coronary valves, or heart failure and cardiomyopathy. So most of the common initial cardiac issues that we see are usually a heart attack. And that's what brings most people into cardiac rehab or to seek out medical care. And with the heart attack, some of these other issues can happen over time. The cardiomyopathy, the heart failure, and other things. Ironically, we're saving a lot more people now, but we're seeing a lot more heart failure down the road because their heart starts to get weak. It has little damages over the time, and we start to see an accumulative effect of that. So different kind of interventions, we'll talk about these in the next slide, but interventions would be a PCI, which is called percutaneous coronary intervention, or angioplasty. Then that's when they balloon open the artery. Then they may put stents in it. We have a CABG, which is coronary artery bypass grafting. That's the surgical repair. I'll talk about that. And then we have valve repair or replacement. We might have the pacemaker or defibrillator implantation or external. And then we have the medications that we use for treatment. Excuse me. So to start with, they're going to do, if you come into the ER with one of these situations, they're going to take you to the cath lab. So the first thing they're going to do is an angiogram. An angiogram is actually the test that they're going to go in and look at this to find out if you have a blockage. So they're going to go in through your wrist or your groin, and they have to thread that catheter all the way up and into the heart. So they thread it through that artery into the heart itself. And then on the left, there's a picture of the angiogram is where they inject the dye so they can observe the coronary arteries. This person happened to have bypass surgery. Those crazy squiggles on the left are the wires from a bypass surgery that wired their chest closed. But so you can see the coronary arteries. They inject the dye, and they're looking for a blockage in the artery. So that's called an angiogram. They go in there and try to see, is this what's going on? Is there a blockage in there that we need to open? If there is, Then they're going to do an intervention, which is called the PCI, as I mentioned. So they have to thread the catheter into where the blockage is. They get into that artery, they thread that catheter in, and then they inflate a balloon that pushes that blockage away and opens up the flow. And then they slide in a stent, which is kind of like a wire cage, to hold that open, and then they pull the balloon back out. In the old days, in my early nursing, we didn't have the technology of stents. So when we'd go in and do the balloon, we'd balloon it open, sometimes and then we took our chances, was it going to stay? So sometimes it popped right back closed, or a week or a month later, it closed back up. But now we have the technology of the stents, which actually can hold it open. So this is an example of that. So sometimes we want to do the least invasive with the lowest risk intervention to get the blood flow restored, right? But sometimes we aren't able to do this angioplasty. Sometimes we have to send them to Anchorage for a high risk PCI with the possibility of bypass surgery. Sometimes that blockage, they have 100% blockage in that artery and they can't get the catheter into it. It's too hard. So what they'll do is, if it's in that case, they'll send it to Anchorage and try with a higher pressure to actually push it open and try to get through there. Obviously, when they put that higher pressure on the coronary artery, there's a risk of it, what we call dissecting or ripping, and then you want to be able to take your mind for bypass if they needed to. But a lot of times they can do that, so we do those high risks down there. Or sometimes the arteries around the heart are tortuous, we can't thread the catheter through there, or sometimes there's a blockage right where it separates, it's in the V, and that's not a very good place to put in a stent because they block up really easily. Or sometimes there's a lot of small diffuse disease or multiple blocks. So there's different reasons why we might not be able to do the angioplasty, and then we'll refer them to bypass surgery. So CABG or bypass surgery, this shows an example of a single, double, triple, and a quadruple. What they actually do is they take an artery or a vein from somewhere else on your body, and then they sew the top into the aorta, that big arch up there where they get a great blood supply at the top of the heart. And then they bring it down and they sew it down below where the blockage is to restore blood flow below the heart. So they actually bypass, the block stays there, they just jump over it and bring blood flow to the rest of the heart. Because what happens is if you have blockage, like say this part of the heart, everything down below it is not going to get blood. So you're going to have a deficit of oxygen and blood to that lower part of the heart, so that heart's not going to work very good. And you risk the death of that muscle if we don't get restore blood flow. So that's examples of, sometimes with a multiple vessel bypass, you can actually have several bypasses on the same artery. There might be a block here and a block here, and it might be the same artery, or it might be different arteries. So then it would be your interventions for your valves. As I mentioned, we have 4 chambers to the heart, and each chamber is separated by a valve. And the valves, the job of the valves is to keep the blood going just one way through the heart. So it goes through the atria, through a valve, to the ventricle, through a valve, to the atria, through a valve, to the ventricle. And they close each time it goes through each section. The valve closes, so the blood, in theory, should only go one way. But sometimes what happens is, as I mentioned, those valves can become incompetent, and so the blood starts going back the wrong way. So if we listen with a stethoscope just as a screening, instead of hearing that crisp lub-dub that we hear is actually valves closing. So when we listen to that, so if we're listening to that with a stethoscope, instead of a nice crisp lub-dub, you can hear a whooshing sound because you're hearing a little bit of backflow. So if with a quick screening, we can do a listen for that, and then we send them for a further testing to find out just how bad the valve is and what's going on. So we have the different kinds of valves. The pulmonic and aortic are similar valves, and then the tricuspid and bicuspid they've got these leaflets to them. And if we decide to go in, we have to go and repair. If it's an aortic valve, there's a new procedure called TAVR. They can go through a vessel and go in and repair or replace it through a catheter. So with that one, we can do it if it fits the criteria, but otherwise we have to go in open heart surgery, just like a bypass, and go in and replace it. There's 2 types of valves that we replace. We can have a biological valve or a mechanical valve. The biological is often like a pig valve or a cow, porcine or bovine, where they'll use that or they can use a mechanical, which is the man-made ones. And there's some kind of fused ones where they have a little bit of both in it. The difference is with a biological, they don't last, they might not last as long. They can last about 10 to 20 years. So if you're young, you may have to have another surgery down the road. Hopefully, the hope would be the technology's better and you don't have to have another open heart to replace it later. Or you might be able to do a catheter replacement. The mechanical lasts long, but you have to have an anticoagulant. They have a higher risk for blood clots, and so you have to be on blood thinners. We're having the mechanicals. So they usually weigh the pros and cons and talk to you about it. So interventions, other interventions with the electrical problem, you might have, as I mentioned, the atrial fibrillation or ventricular fibrillation is the upper or lower part of the heart that's going like this, and it's going erratic and irregular. This top example on the EKG is the atrial fibrillation. So what we do when we go to give them the shock, the idea is it's an electrical system, and we deliver a shock to cause temporary standstill, and then with the hope that we allow it to reset the electrical pacemaker, in the intrinsic one that we have. So this first one shows where that shock happened. You had the atrial fibrillation, the shock and the standstill, and then back into sinus. And so that's atrial fibrillation. And this is ventricular fibrillation. This is a lethal rhythm you're not awake for, or you're not with it, and you won't survive with it. And again, so it shows the shock, and then we're able to get a sinus rhythm. So that's where we use the electrical activity. This is an example of an external cardioversion or defibrillator, how it's placed on the chest. So those are some other interventions we do. Then sometimes we need something permanent for the rhythm. The rhythm, we might need a pacemaker. They might have the rhythm. What often is we have a disorder or abnormality of our intrinsic pacemaker, and we start beating too slow. And so we might put a pacemaker in with a set at a low rate, say 50 or 60 beats per minute. So if your heart rate ever goes down to that rate, it'll kick in and keep a beat going. Some people, it's just a backup and they have it once in a while, and other people, that's their rhythm all the time. They just lost their pacemaker function, and the pacemaker does the work for them. We have internal cardiac defibrillators, and for those cases, and these are just small devices, they're about this big, and they're implanted under the tissue below the collarbone usually, and then the wires are put into the heart, sewed into the heart. So an internal defibrillator is for people who, if they had a sudden cardiac arrest, a sudden cardiac death, we know that they're at high risk for having another one. Or if they have what we talked about, the heart failure, where the output is really low. If we can't improve that with medications and exercise and time, then they're at high risk for ventricular fibrillation. So if they're at high risk for the recurrence of ventricular fibrillation, then we'll put in an internal cardiac defibrillator. So it detects that lethal rhythm, and it'll give a little shock internally. It's smaller because it's right into the heart. It's close to the heart. They do feel it, but it is smaller, and it gets them out of that lethal rhythm. If they have low heart output, sometimes they do a combination with that internal defibrillator and a pacemaker, and it kind of gives a dual purpose, dual help. So our technology has come a long ways over the years in what we can do. But all of these are kind of scary, right? You know, you're coming in, who wanted to have something go on? Then they come into the hospital, and then all this is going on, and they're talking about these procedures, and you might not make it through these, and it's kind of scary. And then they're putting these devices in. So it's pretty overwhelming. People go through a lot of anxiety and fear as they go through this journey. And then medications, that we use medications to decrease the risk factors, to stabilize the myocardium or the heart muscle, and to decrease the morbidity and mortality. So decrease illness and recurrent death and death from after a cardiac event. So the medications help to reduce risk factors significantly and improve quality of life. So we'll always have you on some meds, but we try to have the lowest amount to just keep you at the safest place. At least that's what I try to do with our patients. No one likes to take meds. Okay, so that was a quick scenario of what some of the diagnoses are. Is any questions of kind of just what might bring you to the hospital? Okay, so how do we recover? Well, we usually send you to cardiac rehab. So cardiac rehab, I really believe in it. I've been doing that for a long time, overseeing the program. And we help you get through that cardiac event. Our goal, our number one goal, is to keep you out of the hospital, right? Who wants to go back? It was bad enough the first time, and so we want to keep you out of the hospital. So we help you identify your risk factors. What got you here? And then we try to target those to give you the tools through education to start reducing those risk factors. Because if you don't, it'll come back. In the early days, insurance didn't cover cardiac rehab because they thought, they're fixed. You got this, you opened everything up, they're good to go. But they found out it comes right back. It doesn't take another 20 or 30 or 40 years to come back. It comes back in a year or 2 or 3 if we don't change those risk factors. So we find out as we get older, we don't recover as quickly. We usually have more risk factors. We don't have, as our cells replicate, we don't heal like we used to. We don't recover like we used to. We're not bulletproof anymore like we were when you're younger and do all those bad things, and we keep bouncing back from it. And they realize that they keep having more events. So then insurance started saying, well, maybe we should cover cardiac rehab. Maybe that's a good thing to do. So we really need to get to reduce those risk factors. So we try to help people identify what got you here and then give you the tools to start making changes so that you can reduce those. Obviously, it's a personal choice, right? It's going to be up to what you decide to do and how much you're willing to do. We try to give you the support and encouragement as you take this journey and try to make these changes. And then we try to help you reset or reevaluate your priorities. So that's kind of a big thing to think about. One thing as we start to take this journey, what I try to tell people is they're usually pretty overwhelmed, and we talk about this is kind of a second chance at life. If when you open a newspaper, people that didn't make it through their event, and so you did, and so here we have a second chance at doing something differently. What have I been doing what would I like to do different now? And so that's what we try to help empower them. So we have several facets of cardiac rehab. Obviously, one of the most obvious is the cardiac monitoring. We do telemetry monitoring, like a portable heart rate monitor, and we watch your rhythm and rate just to make sure everything looks good, to make sure the meds are doing the right thing, and you're in a safe place with that. We also measure your blood pressure to make sure the meds are keeping you at a good control. Now, they put you on a lot of meds when you're in the hospital, and when you go home, sometimes once you get back in normal life, sometimes numbers are too low, or sometimes they're still too high as you get more active. So we try to make sure we're in a good range to keep you at the healthiest place with the least amount of medications. And then we might do some pulse oximetry, checking your oxygen levels, because some people, they start having shortness of breath and problems, and we want to make sure they have enough oxygen. So we'll monitor that. We also do exercise for heart health. So everybody's probably done some kind of exercise in their life, whether they did a good job with it or not. But often, and I was one of the same things is you when you start exercising, you do too much, you advance too much, and you push too hard, and then you get really sore or you hurt yourself, and then you got to stop because you hurt so much, and then it's hard to keep back. So after a cardiac event, we have to do it smart. We have to do it with your heart health in mind. So we don't want to overdo it. We don't want to push your heart too much and cause a crisis or a setback. So we teach healthy exercise for the heart and gradual progression and listening to your body. And then we also put a lot of focus on strength training, because as we get older, it's natural that we start to lose our muscle. And as we get older, we want to be able to maintain that muscle mass. We have to keep that muscle mass to keep our bones strong. They have a relationship together. So to keep our muscles strong, then we keep our bones strong, so we're less likely to fall and fracture, because that's kind of a turning point for a lot of people as they get older, is that fractured hip, and then things seem to go kind of south. So we want to make sure they keep their muscles strong and their bones strong, and then also it helps them maintain their quality of life, right? So we need to be able to do that so we can be independent and take care of ourselves. We also there's a lot of education. We talk about risk factor reduction, like I mentioned. Most common problems are high cholesterol or high blood pressure or diabetes. Stress, a lot of people didn't know they had diabetes. It's their first time they find out when they've had a cardiac event. So we talk a lot about reducing those risk factors. We talk a lot about nutrition and diet. We are what we eat, right? So we talk about what does your diet look like? What are you doing? And then if there's weight's an issue, we talk about calories and weight management. We talk about dining out. There's a lot of pitfalls with dining out. So how, what to be mindful of when you're dining out. Try to encourage you to do it less. And we talk about label rating, because we really need to know. We need to be able to look at those labels and know what we're putting in our mouth. At least we try to encourage you to want to know. And then the emotional support. There's a lot of emotions when people go through this. There can be anxiety and anger and depression. A lot of these can lead to problems with intimacy. So we talk a lot about helping them through those. And if they're kind of stuck in some of those spots, then we try to get them a referral if they need it, or just this support, usually going through with other people that had the same thing is often helpful for them. So the next, I like to kind of liken the next part with if you heard of Maslow's hierarchy of needs, right? So that concept is we need to have a solid base of physiological stability to take it to the next level. If once we are physiologically stable, safe, then we go to the safety level. And then once we feel safe, then the next level up is the love and belonging, and then develop our own self-esteem, and then the self-actualization. So I kind of like to use that kind of example as we talk about the same idea for our priorities. What's important to us? What's at that foundation? Often people will come in and they were working 50, 60 hours a week, and they were just this high stress, type A, and I have to do this because I have to take care of I have to pay my bills, and I have to take care of my family, and I have to do all this. Okay, so now we have a second chance. Let's rethink where those priorities are, because I really, really believe if our health isn't that main priority, the rest falls apart. If we don't keep our health, we aren't going to be there for our family when they need us, and we aren't going to be able to pay the bills, because then they lose us, and then we lost out, and they lost out on us. So rethinking it, what is important to us? Making money, the food we eat, taking vacations or having fun toys, your job or work, taking care of your family, your health, your security. Obviously, they're all important, right? But I kind of like to use the example of, they tell you on the plane, put the oxygen on yourself first before you put it on your kids, which is kind of counterintuitive to what you think about. You want to take care of your kids first, but if you pass out and die, you're not going to be there to take care of them. If you're working so hard to bring the money home, but you're not there for your family, and then they lose you, then the rest falls apart. So, a lot of people find it hard to put their health first. They feel kind of selfish. So, but it's really important to keep that health as a priority and then build on that, because the rest is better when you have your health. So we try to help them really look at those priorities and rethink them. So obstacles for attending cardiac rehab, there can be a lot of them. The emotions, there can be, as I mentioned, a lot of emotions that I'll be going through. There's a lot of anger, there's denial, there's frustration. I've had people walk in and throw the paperwork on the desk and said, my doctor told me how to come in. Can you tell me why I have to come here? I don't want to be here. So it's like, okay, let's talk about it. So there can be, and then sometimes there can be someone's really scared of, the lack of understanding. They don't understand what's going on. They're afraid. This is a scary place coming in. They've never been in a place like this. Some of our older women have never exercised, never been in a gym. It's just very intimidating. So there can be a lot of emotions they're going through. So we try to put them at ease, give them the support. Like with that one gentleman, some of them that really don't want to be there. I've had some come in and just say, this is an old man's place. I don't belong here. Because we're seeing people in their 30s, their 40s, their 50s having heart attacks. So it's an all person, men and women. So it's like to help them get over that. A lot of times if I can convince them, just give me 2 weeks. Just try it out. And if in 2 weeks I'm really not meeting your needs, you're not getting anything out of it, let's re-meet and then we'll decide what to do. So most of the time, if I can get them past that first hurdle, they actually start to enjoy it, and they start seeing where they're improving, and they like coming. And in fact, it's a 3-month program, and a lot of them, by the time they get to the end, they don't want to finish. They really enjoyed coming, but it's that first hurdle of that anger that was sometimes helping them through. Sometimes the physical frailty or impairment. Sometimes it's at a point in their life where they've lost so much of their health that it's going to be difficult. They might be wheelchair bound, they might be so short of breath, they might have lots of hip or back problems or knee problems, and they have difficult mobility. So we really try to work with them and be flexible and try to find things that help them, like chair exercises and arm exercises and different things to get their aerobic level up and to help them start getting themselves conditioned and stronger. So we try to be flexible and find ways that we can still meet their needs. Sometimes physicality, they live far away. We have people from the villages, we have people from Delta and Nenana and stuff. And so we try to be flexible with them. A lot of times we'll meet, if they're willing, like with the people, like a lot of them that come from the villages, a lot of times they'll stay in town for a week for their follow-up cardiology visit. And if we can meet with them in that week, and we'll give them an intensive one-on-one session and try to set up a home program. So we got to see where they're at and what their living arrangements are like and what they're willing to do. And then we give them a book with kind of a home program. We do the same thing with some that live way out of town. Sometimes when they live in Delta or Nenana, they're willing to drive in, say, 1 day a week. So they'll come in, we'll do one session we'll do advances and increases and monitoring, and then we send them home, and then give them kind of the tools to do the same thing at home for the week. And then they come back, and we do more advances while they're in there until they're ready to they feel confident. And so we try to be as accommodating as we can. Same with the people with finances. Sometimes they don't have insurance, or they're underinsured, or they have a lot of debt. Sometimes they're still willing to just come to one session, pay out of pocket, and we can do an intensive session and then starting with the home program. Or we help them find out where other resources might be. If they qualified for financial assistance or Medicaid when they're in the hospital, that could cover cardiac rehab. So we try to give them options and let them know where that's at. Sometimes there's other obligations, family obligations, job hours. Sometimes nothing we can do, or they're caregiver for someone. We do as much as we can to try to work around it if we can. Transportation, same thing. We might help them figure out how to get on Vantran, or taxi vouchers if they've qualified for Medicaid or something. We'll try to give them some options for transportation. And sometimes it's just resistant to change. Some people would I've had them just say, you ain't gonna tell me what I'm gonna do. You can't tell me what I eat. I'm gonna eat what I want, and I'm gonna die when I die. I don't care. So it's okay. But the problem is we don't always get that pleasure just to die right away. That sounds weird, but I mean, what happens is often they'll have another cardiac event, but they don't die. But then they lose some more function, and then they have another one, and then they lose more function, and then they come 10 years later, and they're like, help me breathe, get me better. I don't like this, It's like, we tried. So my dad died when he was my age, and he had a heart attack 12 years prior, and he had a lot of worsening quality of life, and so his last 5 years were pretty sad, and it was really hard to see that really a strong, powerful man be so debilitated and have so much of his life taken away. So we have to decide what our choice is. What's our why? How do we want to live, and how do we want to age, and how do we want to die? We have a lot of say in that. Not everything, but we have a lot of say in that. And my goal is to preserve my quality of life, so I can keep playing with my grandkids and travel with my husband and just keep enjoying my life while I'm alive. So that's why I do it. It's just we all have to have personal choices, and we have to decide and take those steps, because they're hard to take those steps and live a little healthier life, but we have to decide it's important to us. So we try to give people the tools and help them through that. So let's consider the basics, though. If we don't go to cardiac rehab, or we haven't had a cardiac event, and we really want to start changing things, what do we do? So first of all, we've got to really start thinking, what are we eating and how much are we moving? Statistics for 2020, 74% of the US population are either overweight or obese. That's really scary. Look at that. So 42% are obese. That's 2 out of every 5 adults. 32% are overweight, 1 out of every 3. And our children, almost 20% of our children are obese in the United States. This is a terrible trend, and it keeps getting worse and worse as we go. So we really have to start thinking about what we're doing. How is this getting that way? So what's leading this terrible trend? Well, one of the things is our serving sizes are out of control. And I don't know, sometimes you don't really realize it. It's just this insidious, gradual trend over the years. But just look at some comparisons, some typical things we might get from 1990 to now. If you look, most of these things at least doubled, and some are tripled and quadrupled in calories. But people don't even realize, because, well, you've always, you get a cookie, you get what used to be a cookie, and now it's like this omega cookie for a whole family. But the serving sizes get bigger and bigger, and we are consumerisms where we want everything. We want more bang for our buck. We want more, right? So this place is going to give me more, so I'm going to go there, right? Because I get more. They're going to supersize and big size and all this silly stuff that we get. The platters are nice and big, and guess what? How many of us grew up with the Clean Your Plate Club, right? So, or it's just because it tastes good. What tastes good? Salt and fat and sugar, right? So it makes things taste good. Our taste buds get used to it, and we want more, so we want more for our money. So we start getting into these bigger caloric sizes of these bigger platters compared to what used to be our plates. And then we don't even realize what we're doing and how much calories we're actually taking in. And then how much, did you eat out growing up? I didn't eat. We didn't eat. Well, of course, we had 9 kids in our family, but we didn't eat out growing up. But now it's the norm. People eat out every day all the time, and not only just fast food or restaurant food or processed foods, the things, so the calories and stuff, the quality of food we're getting is a little bit scary. So we want to start thinking the quality of what we're eating and how much are we eating? And as we get older, we really, I try to empower you to really think from that perspective. So I want you to think about eating less and eating better. You know, move away from that M&Ms and go over to the berries, you know, wonderful fruit and colors and stuff, right? But you're getting better nutrition and less calories. Here's a little look at numbers. A handful of M&Ms is about 100 calories. 100 extra calories a day is 10 pounds of weight gain in a year. Even 10 extra calories a day is 1 pound in a year. Well, what's the big deal with that? But 10 pounds is 10 years. It starts adding up as we get older, right? So we have to, at some point, just stop mindlessly putting stuff in our mouth, but start thinking about it. Is that really worth it? Now I got to go walk on that treadmill for 30 minutes, you know, to work off those M&Ms, right? So we just being more mindful of it because it starts catching up with us. How many calories does it take to gain a pound? Yep, 3,500. So it takes a bit to gain that weight, but it also takes a bit to lose it, right? And the thing is, over time, it's that gradual gaining over time. And as we get older, our metabolism starts slowing down, right? But we keep eating the same, or, you know. And as we get more affluent, we can afford to eat better, and we probably get the more extra calorie foods and stuff. So we have to start thinking about reducing that, a little bit smaller amounts and lesser amounts. So we have to start being mindful of it because it comes on slowly, but boy, trying to take it off is miserable. So I want you to keep thinking about moving to the right. So if you have this food on the left, it's all kind of fun and yummy and stuff that we like to eat, but I want you to start thinking about having that less often. This has to be sustainable and livable over time. If it's some crash thing, you're not going to stick with it, right? So if you gradually start thinking, okay, this is important, I'm going to start trying to make healthier changes. So maybe you, like I had a patient that went out to ate McDonald's every day of the week. Okay, so for him, a step was, well, how about 2 days less? How about 5 days a week? And just start cutting back. And then in those other days, let's start thinking of some other options. And we started giving them suggestions of different foods that they could try. So starting small and making changes from wherever you're at. And then start choosing the leaner meats, the leaner fats, the healthier fats, the fruits and vegetables, the whole grains, the nuts, you know, and start adding those in. Our taste buds do change. We grow new taste buds. It takes about 3 months, and we also our taste buds start to change after 3 months. If we start changing our food intake, it does, but it takes about 3 months to start accepting and starting actually being able to taste a change in those foods. Salt numbs your taste buds. So when you gradually want more and more salt over time to get that zing because it gets kind of numb. If you start getting away from that salty foods, later when you eat some of the foods you used to eat, it's like, oh my gosh, I can't believe how salty that is, but you never noticed it before. But your taste buds do change, but you have to decide that this is important and I'm going to try. You might find down the road as you start going back to some of that salty or fatty foods, you get kind of an upset stomach because your system is liking the healthier approach. So keep thinking about moving to the right. I have some handouts over there. There's tips on making healthier choices, kind of moving foods, and there's also on movement. So I'm going to go into movement next. Is there any questions so far with kind of talking about rethinking food? I like to make food as a journey too. I like to make it look pretty because that's part of my enjoyment. I've had to learn to slow down too. As an ICU nurse, open heart nurse, and as a farm kid with 5 brothers, you know, you had to eat fast because everything was going to be gone before they got it. And then in the nursing, so I've had to learn to try to eat slower, put the fork down, and make it a wonderful journey. Make the food really have wonderful flavors and also be pretty and give it a mental journey as well. And so it's just taking it to start thinking about what we're taking in. So now let's think about movement, okay? How much movement is in your life? So first of all, think about general movement. There's a lot of our jobs are now more sedentary than they used to be. How much aerobic activity you're getting, you know, that getting that heart rate up and keeping sustained for a while. And how strong are you? How much are you doing that you're maintaining your strength and doing some strength training? So I want you to start thinking about that. We've really become, as I mentioned, a sedentary society. We have so many modern conveniences that have removed movement in our life. I mean, you think about it. Oops, I went forward there. So, you know, even just think about the advent of your computers and cell phones and cars, how much we used to do physically more, but now we do less because, I mean, we can do everything from our computer. We don't even have to go shopping anymore. We can order it and they deliver it right to the house. We don't even stand and cook anymore half the time. They can just throw it in the microwave or just have food delivered. So we have so many things. How many we had to get, we talked about party lines before, had to get up and change the channel, if you even had a TV. We didn't have a TV for a long time, and then when we did, you had to change the channel, right, to change the station. You might have had a couple stations. But now we can do everything by the computer or your phone. You don't even have to get up and move. So we actually have to start putting movement back in our life, purposefully, because it's not there if we have to be mindful of it. So I want you to keep thinking, move more, and move to the right. So get off that couch and start thinking about that movement. You know what? And lead by example. Lead your kids, lead your grandkids, because they'll do it with you. And then they'll see you doing it, and you can teach them. We have to start changing our younger generation. We've got to change that trend from where we're going with the obesity and the poor nutrition and stuff. We've got to start changing it. So we need to start leading by example and doing it ourselves. So pitfalls to success. What gets in the way of this working for us, right? Oh gosh, there's lots of them. We don't have time, right? Nobody has time to exercise. Nobody has time to do this. It's just, I like my food. I don't want to give it up. Okay, so underestimating calories, especially when you're eating out. As I mentioned, easily the same meal, if you made it at home or you eat out, it can be double the calories, double the salt, double the fat. So don't even realize that, and then you eat it all, right? So start being more aware of it. Actually trying to count those calories. It's very eye-opening when you actually count your calories. As I mentioned, our modern conveniences have taken a lot of movement out of your life. Challenge your friend. I've said won't ever take an elevator again unless I can't find the stairs. Sometimes I can't find the stairs. And if I'm walking with somebody else, I drag them right with me. We go up to the 5th floor for the education thing. I'm like, nope, you're walking with me. We're going up those stairs. I still get short of breath by that 5th flight, but we have to put that movement in there. And getting discouraged when you're not losing weight, it is really hard, especially as we get older. Our metabolism slows down, everything changes. So one thing I always tell my patients is don't be discouraged, even if you're not losing weight. First of all, if you're eating healthier and you're exercising and moving more, you're making yourself healthier inside. So we don't have to necessarily be skinny to be healthy. We are becoming more healthy inside. But if you're not able to lose weight, the next goal I'm going to ask you to do is don't gain weight. So if we don't be mindful over the years, we will gradually keep gaining weight because we slow down, our metabolism slows down, everything slows down. So being mindful, getting on that scale regularly and looking at it, and like, oh shoot, what's happening? Okay, I've been snacking more, we've been going out more. Okay, let me get back on task. Don't wait till you try on a pair of pants and you can't fit them and stuff. To take responsibility and ownership of that and don't gain. Injuries, like I said, we overdo it. We push ourselves too hard. And as we get older, we don't heal as good. And if there's nothing more discouraging, it's trying to get on step and doing the exercise and then hurting yourself and then falling way, way back. And then it's so easy just to forget about it and not get back on. So that's kind of along the same with falling off the wagon is, it really is a mindset. You have to decide, this is going to be my new life. I will put exercise in my life, and I will start eating healthier. This is my new life. So even if I go on vacation, I'm not going to stress myself and force myself to exercise while I'm at. But I know as soon as I come back, I will get right back on. I'll increase slowly again because I was off for a while. I'll gradually build myself back up, but I will. This is my new life. I will always do it. And you just have to decide when. It's got to be a mindset that you decide that you're going to do this. And then thinking of, some of the problems is thinking of it as a diet instead of a long-term change. Like I said, a lot of these diets, you can lose weight on them, but most people don't sustain them, right? They're not sustainable food that they're going to continue. It's very hard or it's very extreme. And then when they go back off it, guess what happens? Their weight goes back on, and often it rebounds and they gain even more, which is worse. So it would have been better to never have done it at all and at least maintain versus that crash down and then the rebound back up. So instead of thinking of it as a diet and a radical change, just making those gradual changes and moving gradually to the right and just keep moving that to the right. It's kind of a health continuum of just keep gradually moving. Okay, I think I've mastered this. I've given this up, and it's not that hard. Okay, let me try something else. I'm going to take it another step and take it to the next level. So it's got to be lifelong, a change in behavior and lifestyle. And then sometimes social situations are hard, social pressures, because everybody else is eating it, stuff in, so I want to eat it. It tastes, smells good. Or they give you a hard time because you're trying to eat healthy, and they feel kind of guilty, so they make you feel guilty and want to eat it. So you just, and sometimes that just means surrounding yourself with positive friends, people that are going to support your journey, and maybe they'll be encouraged by it and do it too. So it's just those are pitfalls that make it difficult, but it's not unachievable. We just have to decide this is important. So kind of in closing with that, I want you to think of it, first of all, think positive thinking. Positive self-talk is huge. There's a lot of research that shows patients who have a positive self-esteem, that feel good about life and positivity, survive their surgeries better, survive their procedures better. So I like to think of it as just instead of thinking, well, it's never going to happen, or maybe I'll try this, think it will happen. I'm going to do this. This is my new life. This is my journey. I'm going to do it. I'm going to own it. So just continue. And then taking it in small steps and make it gradual so that it's sustainable. And then just keep moving in that direction. And just you got to decide, this is important for me. And that's it. Do you guys have any questions?
I like your picture of, this comes from somebody who raised a lot of children, but I like your picture of the child on the couch and the child exercising, because I think it's in reverse. The kids can teach us how to
Yeah.
exercise. We do have to be a good example for our young kids.
I agree.
But I think we need to learn from what the young kids are
Yes,
doing.
watch their innate
they jump in
energies.
place, they run circles,
Yeah.
they climb.
Yeah.
They're burning, where we say plug them up, they would run the refrigerator, it's.
Yeah. Well, then they get to a certain point where they start to slow down, especially if we're not doing active things in the family. So then they start to slow down. So watching them and watching their energies, but also then encouraging those energies. I have 6 grandkids that live right next to me, and so they'll come down, and so they'll come down for gym day, and so we'll have all my weights and stuff, or my ab roller, and to watch them, it just cracks me up to encourage them. But they're like, "Grandma, this is really hard," But also get out and do those physical things. Get out and take walks with them and bike rides, and just that encourage. They see that, and they see that continuation. So between, how are we doing? Oh, time to stand. I know. So too funny. So I have mine too, and I have a stand-up desk in the cardiology side when I'm working on the clinic side, and so I'm doing my stand-up desk, and then my silly watch says time to stand up. So I have to sit down and then stand back up so it thinks I'm doing something. But yeah. So and that's been kind of fun. It's been helping me.
Stand up.
Yeah. So it's time to stand up. Yeah. But yeah, I agree. And they do see what you're doing, and they do watch what you're doing, and they emulate that. And then we just have to lead by example and follow their example, and then lead by example what we're doing, what we're eating, how we act, and how we move.
And my question is, looking at it, I'm not a medical person. I work in an office that does a lot of medical type stuff.
Yeah.
But what is the difference? The bottom right valve, which was
The
oh, I'm sorry.
yeah.
Can you hear me? The picture showed 4 different valves.
Mm-hmm.
The bottom right one was
You have the mitral and tricuspid, the aortic and pulmonic.
because your picture was like
Back.
it looks so different.
The 2 top valves are real similar in structure, but the 2 bottom valves are different in structure than the top, and one has 3 leaflets and one has 2. They're just different. Because you'll have them come from the right side of the heart, coming with blood without oxygen, comes into the right atria. Then it goes through the valve to the right ventricle, and then it goes up in through a big through valve, and it goes up into the lungs where it picks up the oxygen. Then it comes back. So the quality of the valve is where the pressures in the heart are changed as they come back through. It's going to come back in, and then it's going to push it out through the aorta all the way to the whole body. So there's different types of valves because they function different.
First pictures was the angio.
Mm-hmm. The angiogram or the angioplasty.
So I always thought of it as like cardiac catheterization or whatever, where they go in
Mm-hmm.
and they thread through,
Mm-hmm.
and then they can place a stent
Mm-hmm.
or remove a stent if it's not working, right?
Yeah.
And what else?
Well, they don't remove the stents, but go ahead.
What else can they do in that particular type of procedure? What can they find? What might they find? What might they do in that same procedure without having to go back in later?
So yeah, so what they do is they inject the dye, and they're going to image all those coronary arteries, and they're going to decide if the blockage is or not. So if it's a 80 or 90%, they also do it's called the IVUS ultrasound in there to determine which blockage is the culprit lesion. Okay, in days past they used to balloon all of them open. If they have blockages, they balloon them all. But then the research started showing, well, we should only go and do the ones that are culprit lesion where they showed that they had an active rupture, they had an active, so if it's a severe blockage of 90%, they might go in and do it, or if they find it's the culprit lesion, but there might be other blockages in there. So they document what's there, and then the idea is to work on risk factors to reduce those blockages from growing, getting worsening, or rupturing. So there's a whole science behind of reducing the instability of those other plaques. And then they can also look at the quality of the heart function. They can look at, then they can do an echocardiogram to look at the movement of the heart, which is like an ultrasound, like if they would do with a baby. Whoops. I think I just shut my mic off. Sorry. Okay. Anyway, so they can disconnect. They can look at ultrasound to look at the quality of the heart muscle. And wow, that's loud. And the function, how well the muscle is moving. They can show where there's damage before, but they can usually see if there's been previous infarcts. They can look at damage in there. They look at and then they look mostly at the blood flow.
So, I was going to say one more, just real quick question. Disorders are sent south? Porter Heart, I thought, could do everything.
We can't do open heart.
Okay.
We did an assessment of the community. We take all patients from Denali Park North and the villages. I think it's working again. And then south of Denali Park and the lower area all goes to Anchorage as far as just the first route for medical care. So we looked at an assessment of our community base and how many that we sent that actually had bypass surgery. They have to have a certain percent to actually even consider doing an open heart program. Then you have to have 2 surgeons and a whole team. And if you have to do enough cases to stay competent in the year. So we don't do enough cases in our northern region to support an open heart program. We could to support a cath lab. So, and in that cath lab, we do the angiograms where we go in to look for the stenting. We do the defibrillators, pacemakers. We do cardioversions. So we do quite a few procedures. We do some vascular interventions in there. We had Dr. Ramosi, who's now opening another clinic. So we can do a lot in our cath lab, and we have enough cases to support our providers to have enough procedures in a year to stay competent and stay competent with what they're doing. In the olden days, to have a cath lab, you had to have open heart available. But then over the time, they realized enough of those cases, they rarely actually had to have open heart. To use it, that they were very successful, and we could save people a lot at a better, higher quality of life and save them better getting right into doing intervention. What we used to do before we had the cath lab is we had to give a really potent blood thinner, a clot buster to try to break up the blockage that was in there, stabilize them, and then we'd ship them to Anchorage, and they'd have everything down there.
Just wondering, after a heart event, as you described it, is it safe for someone to go out and exercise right away, or do you have to say you're at a certain stable point and you need to wait before you exercise?
That's a really good point. So I like to get people moving right away, but they have to do it slow and steady. But getting up and moving, so I try to get them in cardiac rehab as soon as possible. In that same week or the next week after discharge, we'll often see them before they've had their follow-up cardiology appointment. And the docs know that we'll screen them and assess them, especially that first day. One of my nurses does a one-on-one and a low exercise and an evaluation. And if we pick up anything of concern, then we won't take them any further until they see the cardiology, and then to take it to the next level. But otherwise, people get bored, they get antsy, and they want to do something, and they get frustrated and angry. So it's usually better to get them moving. Bypass surgery, if I can get them in us within 2 weeks, They usually take a week to get out of the hospital and stabilize. And as long as they're feeling okay, I'll get them in there because they want to do something. And they're more likely to overdo it at home because they're getting frustrated. So then we can watch them and help them gradually get safely advance and give them the tools to understand and to listen to their body. That's the other thing a lot of people don't do growing up is listening to their body. And it's the no gain, no pain doesn't work.
Okay, one more question here?
Sure. Well, after my heart attack, I certainly have a lot more understanding and appreciation of the amazing things that can be done. I'm just truly astounded by it. But then I also wanted to say, as far as cardiac rehab goes, I think that's a crucial piece that I would not have said that before I started it. Because I think coming back from a surgery, thinking business as usual.
Mm-hmm.
I should be able to just step back into my life and how
Yeah.
does this
Yeah.
work? And it doesn't really, and especially as an aging person, it certainly doesn't. So I think it's, you cannot stress enough the value of self-care. Going to hear it again and again and again and again.
Yeah.
But that healthcare is at the bottom of all of that.
Yeah.
And to really take that seriously has been just really changing for me. So, anyway.
Which is
good
wonderful.
job.
It's a wonderful testimony of that. And that's if we can get them to come for a little while and realize that they're getting a benefit out of it, they usually stay and enjoy it and stuff. And like you said, otherwise, a lot of times, when they get out, they think, I'm fine, they fixed me, I'm good to go, I don't need anything more. And it's not accurate, and then they end up getting in lots of trouble. And then sometimes they'll come and they drop out, or they'll come and they really kind of put half of their energy into it, but after the second or third event, and they have a lot more compromise. They're like, well, shoot, I should have listened to you from the beginning. And then they come back, and then they really make life changes. So it's very, it feels really good to see people take control of their life and feel like, wow, I got a new lease on life. I can do this, And then I've had, well, after I left Open Heart, and I didn't know if this was going to be quite as rewarding working in cardiac rehab until one patient came to me and said one day, he said, I am so glad I had a heart attack. What? And he said, I didn't realize how bad I felt, and I cannot believe, I don't remember feeling this good, and I can't remember for how long. He said, and it was because my eyes were awakened by having the heart attack, and the tools you guys have given me to then take control of my life, and I feel great. And that was very encouraging to know, okay, we are making a difference, and we are reaching people and, trying to give them the tools to take control.
That's great. I mean, that's a perfect ending.
All right, thank you.
We can't